Good evening. Let me begin by acknowledging the traditional owners of the land on which we gather and meet, and pay our respects to elders past and present. Professor Crawford, Emeritus Professor Penn, members of the E.S. Meyers family, whom I've had the pleasure of meeting this evening, representatives from the UQ, members of the UQMS, students, distinguished guests, ladies and gentlemen. Good evening, and thank you for having me here. Just as I was walking into the room, I was asked by a student whether I was nervous. So in a fit of anxiety, I Googled nervous. And I came up with a study, the top study, that said people are afraid, that they listed the number of things that people are afraid of in life. And number one was public speaking, and number two was death. So I said to my children, as part of their screen time yesterday, I said, find me a really geeky joke on nerves, something that fits a doctor who doesn't do jokes. So they came up with a good one, at least it pleased me. The only thing that gets on my nerves is myelin. So you have my 10-year-old to thank for that one. It is my absolute pleasure to be here tonight to deliver the prestigious E.S. Meyers lecture. I pinch myself. In doing so, I follow in the footsteps of such luminaries as Nobel laureate Peter Doherty, mountaineer Sir Edmund Hillary, and cricketer Imran Khan. Peter Doherty, whom I've had the pleasure of meeting and being on a panel with, is absolutely charming and erudite. It would really be fascinating to hear Sir Hillary's take on courage and resilience. And every single Indian person of my generation has had a fixation on Imran Khan. Not just for his good looks, but what he has single-handedly done to revive or plunge relationships between India and Pakistan, depending on how he captains a cricket team. Get that? But as a doctor, I can't help wishing that I had been present to listen to Professor Meyers, who was not just a founding father of the UQMS, but indeed a shining light for the entire medical profession. I have no doubt that being merely present in his presence must have left a lasting impression on all those who were fortunate enough to hear him. And I'm particularly grateful to the Meyers family and to UQMS in letting me play a big part in keeping his memory alive. And what a wonderful memory it is. I would also very much like to acknowledge the medical students and volunteers who have made this night possible by working tirelessly behind the scenes for months and months. If their application to this task is anything to go by, you'll make your patients proud. In thinking about this address, I have felt a tremendous responsibility. I've also remembered Oscar Wilde saying, "Be yourself, everyone else is already taken." Good advice. It's no small task, though, to keep a crowd of hundreds, peers, engaged for an hour. So this is something important. You have my permission to nod off, but I will make a pact with you and I'll wake you up for the important bits. Some time ago, I got into a discussion with an investment banker about the future of medicine. The banker envisioned a future without doctors, a future where robots will outperform, overwhelm, and eventually replace doctors. I wasn't offended, but I was certainly struck by how narrowly the banker viewed the work of doctors. But first to his arguments, and he had some really valid ones. Artificial intelligence can do what doctors are finding increasingly difficult. They can collate vast amounts of data, produce algorithms, and do things in a fraction of the time doctors take. Doctors are fallible, distractible, and forgetful. We can't keep track of the nearly 1 million studies published each year. As a result, doctors misdiagnose, misprescribe, and even mislead. When surgeons operate, they leave behind an instrument in 1 in 10,000 cases and operate on the wrong side 1 out of 100,000 times. Surely, a robot would know how to count better and see clearer. Machines are already helping diabetic patients finesse their insulin dosing, and joint replacement patients receive better post-operative care. Computers with literally millions of bits of information in their database, are capable of accurately and rapidly identifying diseases and churning out the latest evidence-based protocol to treat with. Turning to my own field of cancer medicine, each year sees the publication of 150,000 journal articles, impossible to keep up with. The global spread of people, risk agents, infections, and lifestyle factors means that any type of cancer patient can now crop up anywhere. With an aging population, the incidence of cancer is on the rise, and our clinics are filled with people who need to be seen. IBM has built a computer called Watson, whose mission it is to incorporate all available data to come up with personalized cancer treatment. Wouldn't it be so much easier to feed all the patient information into a computer and get the solution in an instant? As an oncologist with an intimate portrait of people's lives, I think the answer is a firm no. This is because when we fall ill, the healing process entails much more than the application of evidence. Patients see doctors for management of their condition, but that condition has many manifestations. The physical suffering is of course important, but no less is the emotional burden. When patients are suspected of having a life-threatening diagnosis such as cancer, they want many things. They want to know what the diagnosis is, and they want to know how I will treat it. They want to know the ins and outs of chemotherapy, whether they will lose their hair, be rendered infertile, and break their nails. But behind these worried, factual questions, there is an entire layer of questions that goes something like this. Will I live to see my daughter start primary school? Will I make it to our next family vacation? Will I be well enough to greet my grandson at the airport? If I decline treatment, will my family forgive me? And behind these questions, there are expectations. Not only that their oncologist will use the full knowledge and authority to treat the cancer, but that he or she will understand, empathize, and promise to be there for the whole journey. The fear of abandonment looms large in the minds of all chronically ill patients. In other words, if my diagnosis stops being interesting, and if the drugs run out, will my doctor still care about me as a human being? A GP friend of mine tells me that on some days, a good half of his practice consists of patients who present with a minor cold or a mild headache, but whose real problem is loneliness, depression, or anxiety. This diagnosis is gleaned not merely by asking the right questions, but by sensing the twitching lips, the misted eye, or the tensed body. In fact, I would argue that one would miss the diagnosis by feeding in the reported symptoms into a computer. Make no mistake, reassurance, kindness, empathy, touch, and even placebo play a vital role in medicine. They aid understanding, compliance, collaborative care, and enhance quality of life even when the survival graph remains unchanged. People repeatedly tell us that even when they can't live longer, they want us to help them live well. The human touch ultimately lends form and meaning to protocol and evidence. Without it, medicine would be sterile, just as capable of being doled out by an investment banker as being practiced by a trained doctor. Sure, we stand to benefit from computers. Every day in clinic, I'm glad that a computer algorithm can tell me more quickly than my head which drugs I'm prescribing are at risk of interacting with the next, or whether I've thought about reducing the dose of chemotherapy for a patient with kidney disease or liver disease. Another system helps me keep track of missed appointments, and another weighs multiple variables and tells me the life expectancy of a patient so that I may not compromise it further with my drugs. Computers are excellent aids, and they help keep track of safety and efficiency. They will become increasingly useful in practicing distance medicine. In countries with a stark lack of doctors, I would rather be diagnosed by a robot than not be diagnosed at all. Although the still prohibitive expense of artificial intelligence really means that poor populations won't be seeing its benefits on a large scale anytime soon. News of the doctor's demise may have been greatly exaggerated, but there must be reasons why an intelligent banker thinks that a robot can replace a doctor. I wonder if medicine could be a victim of its own successes. It's generally evident that the science of medicine has advanced beyond imagination. 50 years ago, the treatment for a heart attack was to put the patient in a dark room and give morphine, if available. Today's heart attack patient has a high chance of not only surviving the insult, but going on to lead a healthy and full life. Indeed, mortality rates from heart disease and stroke have fallen by 70% since the 1970s. That's remarkable. I was a medical student in the 1990s when the world was being ravaged by HIV/AIDS. The gaunt, stricken faces of AIDS sufferers haunted us all, and the HIV ward of the hospital was a pit of misery. I remember very well treating a single mother dying of pneumonia and standing outside her door with a team of senior doctors, all of us tearful at what would happen to the little girl, HIV positive, and innocently unaware of her own fate. Today, the HIV ward is a relic of the past, and the dreaded killer has been tamed into becoming a chronic disease. My own field of oncology has been transformed by the advent of genomics, allowing oncologists to provide hope where previously there was none. You can similarly look at any area of medicine and recognize scientific advancement that has helped the cause of millions of patients. But what seems to not have kept pace with the science is the art of medicine. Gone are the days when a doctor might hold someone's hand and minister comfort in a time of need. Now, there are tests to leap to and interventions to organize, but ironically, the availability of so many more options has worsened the state of doctor-patient communication. The vast majority of healthcare complaints today relate to a failure of communication at some level. There is so much to do that there seems to be no time to talk. So, if robots can do the work faster, no wonder someone has started to think whether doctors could be altogether indispensable one day, or dispensable rather. Let me share with you part of a text message a patient sent to me the morning after I met her recently. A previously well school teacher went to her doctor with heartburn and left with the diagnosis of terminal cancer. "I just wanted to say thank you," she wrote, "for making me feel like a human being and not just a statistic when we met. It is so important to feel that someone cares and that someone will help fight for your life even when your prospects are dismal." I can't help thinking that doctors are not about to go out of fashion anytime soon. But we do hope that each new generation of doctors will usher in positive change. So with this in mind, here are a few reflections I would like to share with all of you poised to become future doctors. And by the way, if you've been nodding off, this would be a good time to wake up for a while, just a while. Firstly, learn to listen. Older studies have shown that on average, doctors interrupt their patients every 20 seconds. I have tried to disprove these studies in my own clinic, but I suspect that they're not far from the truth. I imagine no one wants to repeat these studies, which might possibly yield even worse figures today. The reasons we interrupt our patients are varied, but they all aggregate around the notion that we want to bring patients back on track. We want them to tell us edited versions of their story so we can get on with the task of helping them. But when we interrupt, prod, and nudge our patients to give us the relevant facts according to our definition, we lose a tremendous opportunity to learn from them about what really matters. If you allow a patient to talk unfettered a little while, you aren't wasting time. Rather, you are observing precious details. simmering anger on part of the patient, subtle frustration on part of the spouse, a communication of their deepest desires or fears that they don't quite know how to articulate openly. As William Osler, another famous physician, said, "More is missed by not looking than not knowing." Every doctor should remember this every time you're at a bedside. Practice humility. Medicine is an exciting, intellectually stimulating, and downright awesome profession. It is also widely feted and admired by outsiders. It's no secret that entry into medicine is so extraordinarily competitive that people miss out by a hair's breadth. For every one student that gets into medicine, there are more than 100 who don't. So that entry into medicine is occasionally accompanied by a feeling of superiority. In medicine, unfortunately, arrogance is common. And many people have said to me that it seems to be almost a flip side of having worked so hard to get to the top that you want to guard your position jealously. After all, the pedestal is quite narrow and contenders many. But the very best doctors that I have met are those who think of medicine as service and who sacrifice individual success for the betterment of the lot. A career is something you pick. A vocation is something that calls to you. The best doctors recognize the limitations of their knowledge and expertise, and they are unafraid to own it. Humility is underrated, but there is nothing more attractive in an intelligent, well-read, well-spoken doctor than a dose of humility. So learn to be humble towards your patients and towards your colleagues. Acquire perspective. The dictionary describes perspective as an outlook, a viewpoint, or a frame of reference. In medicine, I like to think of it as the big picture. Despite the advent of better drugs and better technology, our patients keep telling us that they aren't satisfied with the quality of care. Some of this is explained by consumerism, but it's increasingly the case that every doctor manages his or her narrow area of interest, and the patient feels lost in the labyrinth of healthcare. Who is really in charge of me is a worry on the minds of many modern patients. If you are standing at the bedside, though, that patient is your patient, deserving of your full attention. Because that patient, first and foremost, is a person, not a collection of diseases. Perspective comes with age and experience, but also from listening carefully, consulting openly, and not being afraid of opinions that are counter to your own. Medicine will tease you every day with glimpses of all that you will never know or remember. There is an ancient prayer that goes like this: I will not ask thee for improved memory, only for a little more humility and less self-assurance when my own memory doesn't agree with that of others. Teach me the glorious lesson that occasionally I may be wrong. Every doctor should commit this prayer to memory. Be kind. Maya Angelou, the great poet, once said, "They may forget your name, but never how you made them feel." I think this is very true for every doctor-patient interaction, the good, the bad, the uplifting, and the terrible. When I was a young doctor, I lost my first twin pregnancy, something I've written about publicly in The Guardian as well as in my book. I remember many things about the loss, the senselessness of it, the numbing grief, and the mute despair. All that settled with time and the blessing of children. But what I can picture just as clearly today is that my obstetrician was kind and was himself moved to tears as he gave me the news that the twins were dying. I can't measure the value of those silent tears except to say that in an instant he eased my suffering and humanized the medical profession for me. There will be times when you too will feel helpless because you don't know the diagnosis, you have run out of treatments, or there's nothing else left to say. But remember, that there's always, always room for kindness. And you will fill many holes with a simple touch, a kind word, and an understanding expression. There is no protocol for being kind, but I would urge you to never underestimate the value of compassion. Find a mentor. The story of Mentor comes from Homer's Odyssey. When Odysseus, king of Ithaca, goes off to fight in the Trojan War, he entrusts the care of his household and his son to Mentor. Mentor serves as a teacher, a guide, an advisor, and a friend to Telemachus, eventually helping the son reunite with his father. Think of those words: teacher, guide, advisor, and friend. We all need a mentor, someone to provide pragmatic advice and higher inspiration. It's said that the mind isn't a vessel to be filled, but a fire to be kindled. I have been extremely fortunate to have some very good mentors in my life, but here is the thing: they're not all doctors, and in this, I count myself doubly fortunate. For you can learn about character, integrity, and perseverance from all sorts of people. So don't be afraid to look beyond the walls of medicine to find someone whom you can lean on. Go out and save the world. So this is my next wake-up call to all of those who nodded off. Go out and save the world. I say this with a hint of irony, but also an element of plea. In my first year of medicine, a global health professor asked us how many students intended to work or volunteer in the developing world. Nearly every hand shot up, but merely 6 years later, as we stood poised to graduate, those dreams were being watered down by thoughts of what specialty training we would enter. Then, as we hauled ourselves through the rigors of training, the realities of marriage and mansion set in. How could one possibly manage Ethiopia with the kids? How could you work in Afghanistan when you had a mortgage to pay on your dream house? Closer to home, would investing a year in indigenous health make or break a carefully curated CV so far? The reality is that we all enter medicine to make a difference, but it is the rare amongst us who will do this in truly disadvantaged, impoverished, and needy populations. According to World Bank figures, very low income and conflict zone countries have less than 5 doctors per 10,000 population, compared to the OECD average of 28. Canberra, with its population of just under 400,000, is served by 2,000 doctors. The 11 million people of South Sudan get on with 200. There are many practical reasons why all of you won't end up working where you are truly needed, but it doesn't mean you can't make a difference. You can start at the bedside, believing that every action you take has a subtle impact elsewhere. You can be aware, for example, that by prescribing antibiotics indiscriminately, you are actually contributing to a global problem of antibiotic resistance. You can be aware that by prescribing the newest, most fashionable Me Too drug, you are encouraging drug companies to go where the greatest profits call, instead of where the biggest need is. You can be aware that with the borders of the world having become more porous, you can be an advocate for asylum seekers in your own backyard without ever having to set foot in the hell that they come from. Barely a week seems to go by in my clinic when I'm not presented with the plight of a refugee patient struck by serious illness while dealing with the ordeal of having left behind home and heart. All these patients rely on the charity of volunteers and organizations to get by. The stories are so compellingly sad and traumatic that it is even a doctor's first instinct to stay at arm's length from problems we can barely imagine, let alone solve. The easy answer, even for doctors, is to pretend these problems don't exist and seal ourselves in the bubble of our first world existence. But do note that the world's problems don't go away because you cease to look. You can also engage with these patients, listen to their story, acknowledge their struggle, and do whatever little you can to help. This usually means begging the executive to cover costs, begging for compassionate access to drugs that are otherwise unaffordable, and repeatedly explaining issues to one's own colleagues who are impatient because they've never had to deal with these problems before. But it means believing that we can be a small part of the solution. This week for me, it meant spending an hour with an Iraqi professional couple separated from their children in the process of seeking asylum, and now coping with the wife's advanced breast cancer. Imagine being terminally ill and having no physical access to your own children. Imagine being grateful for just having a phone so that you can at least hear their voice. I told the couple that I admired their resilience and that they were in safe hands, and watched as their tears fell. Reassurance, empathy, and consideration are some of medicine's greatest gifts to patients, and they're indeed universal. I couldn't help thinking that the robot would still be asking for the patient's Medicare card. If you woke up, stay awake. If you have slept through the whole thing, it's a good time to wake up. Find a life outside medicine. Medicine has the capacity to swallow your life, but there's really a lot more to life than being a doctor. Some years ago, a young woman came to see me. She was a very bright trainee, hoping to sit her physician's exam, but unexpectedly found herself the mother of a toddler as well as newborn twins. She said that between feeds and changes and naps, she was trying to study, but it was proving impossible. She blamed herself, and then she asked apologetically what she ought to do. I thought about it for a bare second, and I said, "Don't sit the exam." She was astonished, saying that in all the months that she had sought counsel, no one had ever offered her this advice. I felt very sad that no one had. I told her that her children would grow up, but the exam was going to stay put. She might take it the next year, or the year after, or 5 years hence. Perhaps she would never attempt it again now that her priorities had changed. So she mightn't become the specialist that she had always dreamed of, but being a good parent who was available was a completely credible measure of human success. All too often in medicine, we are measured by a list of our achievements, but these achievements extract a heavy toll. You all know that medical students and doctors have a significantly higher rate of stress and substance abuse than the general population. The statistic doesn't just apply to others, it applies to all of us, to you and to me. So learn early to take care of yourself and to not hitch all your dreams to medicine. Nurture an interest, whether it be painting, playing an instrument, writing, coaching a kid's sport team. Volunteer at your high school, church, or your food bank, but do something that takes you away from the walls of the hospital, where unfortunately success continues to have a very narrow definition. I try to keep in mind the wise words of Michel de Montaigne, the French philosopher, who said, "On the highest throne in the world, we still sit only on our own bottom." At this point, I'm beginning to warm to Will Rogers' sage remark, "Never miss a good opportunity to shut up." We're nearly there. Have another nap if you need. Meanwhile, I'd like to expand on the theme of doctor-patient communication and its very serious implications by reading you an excerpt from my book, Dying for a Chat. This is a story about a patient called Mrs. Johnson. And Mrs. Johnson was in her 90s. I looked after her on the medical ward on my unit, and really the book was written as a mea culpa. She was very ill. She had been admitted to hospital with pneumonia. She was only admitted into hospital, as many of you will recognize, because she came from a nursing home and the nursing home wasn't willing to take her back on a Friday night because there wasn't enough staff. She could have done with oral antibiotics, but because she came into hospital, someone stuck in an IV. Once the IV went in, someone thought we might as well give her intravenous antibiotics. The IV site became infected. The infection tracked up her arm, and then the rest follows. Her latest numbers look bad. Her kidneys are protesting and something will need to be done urgently. Mrs. Johnson, there's been a serious change in your health. Mrs. Johnson, we need to talk about a difficult subject. Mrs. Johnson, we will need your help with this. These are the things she needs to hear. Instead, I hear myself saying, Mrs. Johnson, we'll need to work on your kidneys a bit. I hate its deliberate vagueness, hoping that she will ask me some leading questions that will lead us back on track. What will you do? She asks. We'll try some fluids, and I've stopped any pills that might worsen your kidneys. Sometimes that's all you need to turn things around, I say, omitting to add, and many times, despite doing these things, your kidneys keep failing, which means we should talk about that eventuality now. I suspect I must sound reasonable and reassuring enough because her expression in no way reflects my private alarm. Later that day, driving home, I wonder how one day my doctors might relate the news of my renal failure to me. Would they own up to at least partial oversight on their part to its cause? Would they explain things on a need-to-know basis, or would they have a full discussion with me about the implications of my condition? Would they think of me as a diagnosis or a person? I know what kind of engagement I would want from my doctor, but I doubt that I will receive it. Medical sophistication will be so much more extraordinary that I suspect doctors will gloss over their mistakes even more easily because technology may afford them a tempting escape. My thoughts end in a resolve to come clean with my patient. The growing layers of complexity of her case disturb me. This isn't how things were meant to unfold. Tomorrow, I will pull up a chair, sit down, and ask her how she is really doing. As things stand, she is receiving day-to-day care, but I would like her to appreciate the big picture. I suspect she is spiraling downwards, and I fear that her fate will match her husband's, which is what she dreads most of all. Tomorrow, I promise myself, things will be different. This isn't the way I want to practice medicine. That night, fatefully, Mrs. Johnson has a medical emergency call for slipping into heart failure. The fluids trickling in to rescue her kidneys overwhelm the delicate function of her heart. Her breathing becomes so difficult that she can't speak, and she clutches at her chest in panic. I receive a call at midnight from the senior resident. She might have had a heart attack. You know her best to decide how far we should go. My voice answers, but my mind still feels stalled in sleep. Ask me that tomorrow, I want to protest, and I might have an informed answer for you. I find myself saying she is 90 and has a poor prognosis. I think you should make her comfortable, but not venture into heroics. Although I have privately thought this for some time, I feel deeply torn saying it behind the patient's back. Yet, it's the right decision for her, tired and worn down at 90. What does she want? I add. She can't talk, but her daughters want everything done. What did you ask them? There is a pause on the line. It's the doctor's admission that although clumsy, he used the only way he knows. I said, if your mum's heart stops beating or her lungs fail, do you want us to let her go or do everything? Plaintively, he adds, and they said they wanted everything done. I close my eyes at the thought of the exchange. When a doctor paints resuscitation as a stark choice like this, the answer from most families is unsurprising. I would do the same, I say, unable to keep the disappointment from my voice. They said you were talking about a discharge date, the doctor adds, reminding me that I too am responsible for my share of false optimism. So what are you going to do? I called ICU. She's going to intensive care? I asked disbelievingly. Well, they have a bed. But that will be terrible for her, I say to no one in particular. The intensive care doctor comes on the line. She doesn't look good, she begins, her voice laden with remonstration. No, I agree. She looked sick when I left. We could take her to ICU, but I don't like her chances. I don't think she should go to ICU, I say. Well, it's not that easy. We have a patient who isn't saying much, a family who wants everything done. I'm thinking the easiest thing to do is to take her upstairs, stabilize her heart, filter her kidneys, and see which way it goes. See which way it goes seems code for either we or the family will figure out that this is useless. I'm desperate to not have my errors with the patient compounded by another series of futile actions. Wait, can't you talk to the daughters? I don't think they're in the mood. And really, these things should be done by the treating team in non-urgent settings. That the intensive care doctor is annoyed is clear. Intensive care doctors are commonly caught in this bind, although to now abnegate responsibility doesn't seem entirely reasonable either. I observe the rapid parting of our ways. I'm suggesting, let's think this through. She's arguing, not tonight. We will use technology to tide her over until you sort it out. I try again. My sense is that Mrs. Johnson wouldn't want this level of intervention. If we let her die tonight, we may have a lawsuit on our hands. Unfortunately, this clinches the argument. In intensive care, the daughters are shocked at the sight of their mother, whom they spoke to just 12 hours ago. They had read her out an email from her sons and talked about her grandchildren. She had asked whether anyone from the nursing home had asked after her in the weeks she had been away and expressed a desire to get out of hospital soon. And now here she is, looking moribund, dwarfed by beeping machines, gowned doctors, bright lights, and pensive faces. Was this what became of the patient whose doctors employed the words hope and optimism in meting out her care? We probably need to intubate her to support her breathing, but she is too confused to give consent. A new intensive care doctor says to the daughters the next morning, "What would you like us to do?" "We want you to fix her." The thing is, there's only a small chance that she could improve with intubation, and if her kidneys get worse, we will be looking at temporary dialysis. She could be here for a long time. The intensive care doctor seems to believe that his measured words signal to the daughters that they shouldn't entertain following this course of action. But to the stricken daughters, his words are proof that there is still a chance of recovery. There are more superior machines here in intensive care, probably even more skilled doctors and nurses too. There is one-on-one care here, surely a recipe for improvement if there were one. The sickest people go to intensive care because it's the place that fixes them. Maybe this was where their mother should have been from the start. As long as there's a chance of her pulling through this, we want you to do everything. The doctor feels cornered. He knows what he would recommend, but recognizes the unpreparedness of the family to enter a discussion about end-of-life care. Expressing his frustration, he says that he will do the only decent thing he can think of. We will intubate her, but review the situation in a day or two. While everyone is glad for the temporary reprieve, the doctor rues that, like everyone else, he too has selected the easy way out. He curses the system for creating the mess. In keeping with everyone's expectations, except her children's, Mrs. Johnson fares poorly. Without intensive care, she would die, most likely of painless renal failure. But within the walls of this modern wonder which houses the most startling inventions of medical science, she lives. A machine does the work of her lungs, and another stands in for her kidneys. Other devices appear from time to time to draw some more blood, to put in a bit more drug, to give some fluid, to take some away. It's a matter of time before she develops hospital-acquired pneumonia, which is potentially fatal. She hasn't eaten in days. The family wonders now whether it is the lack of nutrition that is impeding her recovery. There are repeated phone calls from her sons, wanting everything done to keep her alive, while they tie up their business and rush home. There are no threats or demands, just pleas, coming from good people who have every faith that doctors save lives. It is their dear mother's turn now, and the doctors will deliver. It's only a matter of time. This is how Mrs. Johnson begins to receive artificial feeding. It's a week in intensive care before her 4 children come together at the bedside, their tear-streaked faces reflecting disbelief. The most senior doctor has told them their mother won't improve. He has gone further, recommending withdrawal of care. Their minds are reeling. They plead for time in which they seek a second opinion and then a third, all the while praying for signs of improvement. Finally, a full 10 days after their mother entered intensive care, she is extubated and anointed. But to add another tragic twist to the tale, she doesn't die within minutes or hours as they had been told to expect. Incredibly, she lasts another 24 hours with flickering life, enough to drive the point home to anyone who is watching that this whole thing is just wrong. She hasn't even died when the recriminations begin. The nurses who cared for her on most days now say that her death was inhumane. The doctors are disheartened, some at their inability to turn things around, the more insightful ones at this revolving suite of very old and sick patients entering intensive care when their only chance of recovery is theoretical. The children are heartbroken, bewildered, that though it feels as if the staff always knew, nobody warned them about their mother's death until it was about to happen. They're tortured by the decisions they made on her behalf, having witnessed the suffering it added. Of course they wanted everything done, but why didn't anyone explain what everything really entailed? There was never really a serious hope for her survival, but why didn't someone spell it out? Why didn't someone say, I know you are upset, but this is not in your mother's best interest? The bureaucrats, always ready to weigh in on doctors demonstrating fiscal irresponsibility, brand the death as another negative outcome and rue the hundreds of thousands of dollars in bills racked up by a little old lady at the end of her life. They draw graphs and build comparisons, telling the doctors yet again how healthcare dollars really ought to be spent. And poor Mrs. Johnson, the central figure in all of this, she's dead, a passive participant in her own care, although it's fair to say she would have decried the events of the last months of her life. Long after she has died, Mrs. Johnson's case keeps turning in my mind. The taste of dissatisfaction and an unfulfilled contract of care rancid in my mouth. Was it my fault? Or was it a collective failure of imagination of finely trained doctors to separate fact from illusion? How is it that doctors charged with helping people end up harming them? Who should be held accountable for the family's deep and ongoing distress that will forever color their experience of hospitals? Nearly a month spent in the hospital of a healthcare system widely regarded as the best in the world. And this is all one gets? Dissatisfaction, unhappiness, and recriminations? How did it come to this? If the patient is dead, the family is dissatisfied, the doctors are disillusioned, and the bureaucrats are disapproving, who is it that modern medicine claims to serve? The book goes on to make an argument for teaching doctor-patient communication and why communication underlies so much of what goes wrong in healthcare. I wrote this book simply because I was really troubled by medicine's failings, but also my own shortcomings, and I held myself responsible for what happened. In the latter part of the book, I speak about the importance of having advanced care directives and of making communication a priority in medical school training. And I must tell you that along with everyone in the audience, I was myself astonished when I won the Human Rights Literature Prize for this book. No one had ever heard of it. But it reminded me that just like we say living well is a human right, so is dying well. And I think that the reason that the Human Rights Commission recognized a book, of all things, is because it promotes the idea of dying well and how we die well as a society. I don't think for a reason that winning a prize for a book makes it any easier to live by one's principles, but I do think that a lifelong pursuit of becoming a better communicator is a worthwhile endeavor. I'm nearly at the end of my talk, and you've been very patient, and I'd like to finish by tackling a most frequently asked question of me. What is it like being an oncologist? Which is closely followed by, mustn't it be depressing? I don't think it is, and I'll finish off with reading you a little bit from my book. Being mindful of the lives of patients has made me more mindful of their death too. One of my very first patients bled to death. I still remember the impact of witnessing that barbaric death, and even now, walking past that room transports me back to that afternoon. My hands shook as I wrote the death certificate. My first few losses after this made me sad and introspective, but some years later, especially on busy nights, I found myself certifying deaths as if writing a prescription for an antibiotic. But now, I close the door behind me and spend a still moment taking in the surroundings. I look at graying wedding photographs and pictures pasted on cardboard depicting regular family events, a profusion of cards, some with a child's wobbly drawing or handwriting, flowers from a well-tended garden, the last music someone listened to, the last book he read. This moment reminds me that every death robs someone of a child, sibling, parent, or partner. Every death closes the book on a life that doctors barely knew. And I'm reminded to not be arrogant before death. A quiet and reflective moment spent in the presence of the dead provides fresh insight into the gift of life. Despite many advances in oncology, a large proportion of my patients succumb to their disease. I wouldn't have thought it, but one of my most cherished tasks is to call their surviving family. I still approach the task feeling tentative, not knowing whether the relatives will choose to cast blame on the disease or the doctor. This fear sometimes leads me to avoid calling certain families. But I'm constantly struck by the surprise and gratitude of grieving relatives for a simple phone call. In all these years, I cannot recall a single family that has taken undue advantage of the gesture, but many have said that it has renewed their faith in the medical profession to be remembered in the aftermath of their loved one's disease. A colleague sets aside time to write notes to grieving relatives. Once, a copy mistakenly arrived on my desk. I didn't know the patient, but reading the note caused a lump in my throat. In just a few words, the letter celebrated the elderly patient and saluted his wife for undertaking the demanding journey of cancer with him. It's hard to overestimate the consolation that those words must have brought. But perhaps the single most important thing that I have learned from being an oncologist is to be grateful. I'm simply grateful for my life and for my health. Many of my patients have incurable cancer. Lately, I have taken to closely observing the trigger that led to their diagnosis. The answers are so benign that they would invite good-humored disbelief were it not for the patient sitting before me. My hand just went to it. My job required a chest X-ray. I turned in bed and just felt a lump. Many patients were leading a perfectly normal life in the days or weeks before the calamity fell. Their revelations are a sobering reminder of the instant power of disease to change our lives. What I've learned from my patients is that it often takes the diagnosis of a dire illness for them to reevaluate their life and place the small things in perspective. That poor girl, an old lady once said to me, "She looks so sick. I don't mind if you see her first." I looked at her in admiration. She had a brain full of metastases, yet she cared for someone else's welfare. My patients talk to and about their children more. My patients worry less about money, fame, or fashion, and concentrate more on being at peace with themselves and with society at large. They have finally come to understand and despise the trivial issues that we let crowd our lives. Maybe it really is as simple as that. But I never fail to wonder what it is in our makeup that prevents us from appreciating these things a little earlier. I'm grateful for being able to think, talk, and walk. Life is good just as it is. And on the days that my own mind needs convincing, I simply stop by at a patient's bedside. Ladies and gentlemen, thank you so very much for your attention and good evening.